Hello, everybody, and thank you for joining us. I'm going to give us just a minute or so to let folks trickle in. I do see the room filling up. Okay, amazing. I will get us started. So hello and welcome, everyone. Thank you so much for joining us for tonight's presentation, Overview of Comprehensive Behavioral Intervention for Tics in Adult Patients with Chronic Tic Disorders. My name is Alexandra Walsh, and I am the Manager of Programs here at the Tourette Association of America. I'm also joined by my colleague, Dao Duong, Senior Manager of Community Programs, who will be helping me out tonight. Tonight's program is being provided as part of the Tourette Health and Education Program in partnership with the CDC. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the US government. After the program, we'll be asking attendees to partake in a brief survey to let us know what you thought of tonight's program. Tonight's session is made possible by support from the CDC. So not only is your feedback important to us, but also demonstrates to the CDC the value of programming like tonight. With that being said, I'd like to introduce our speakers for tonight's program. First, we have Dr. Peter Morrison. Dr. Morrison is currently an associate professor of neurology at the University of Rochester Medical Center in Rochester, New York. He graduated from Bucknell University in 2007 and received his medical degree from the New York College of Osteopathic Medicine in 2012. He completed his medical internship, neurology residency, and clinical movement disorder fellowship at the University of Rochester. He joined the Department of Neurology faculty in 2017 and specializes in the care of patients with movement disorders, including Parkinson's disease, essential tremors, Huntington's disease, dystonia, and ataxia. Dr. Morrison also has a special interest in the diagnosis and management of children and adults with Tourette syndrome and other chronic tic disorders. And he is the co-director of the Tourette Association of America's Center of Excellence at the University of Rochester. Next, we have Hannah Peck. Hannah is an occupational therapist at the University of Rochester Medical Center in Rochester, New York. She came to the University of Rochester in 2016 after completing the UR Len Fellowship. Hannah treats a variety of developmental, orthopedic, and neurological conditions in outpatient pediatric rehabilitation. She completed TSBTI training with the TAA in 2017 and has been working with adult and pediatric patients with tics and Tourette since then. With that being said, I will turn it over to tonight's presenters. Thank you.
Hi, everyone. Good evening. It's a real pleasure to be here today. Again, my name is Pete Morrison. I'm a movement disorder neurologist, and I've really appreciated, the opportunity to present various topics to patients as well as care providers regarding Tourette syndrome. And this topic is actually a little bit near and dear to my heart, as I'm someone who is also diagnosed with Tourette syndrome and has had it for over 30 years. And don't want to necessarily do the math there to figure out my age, but obviously, today I'll be focusing on from a provider, a physician perspective, but I'm also someone from a patient perspective that, understands and what it's like to have Tourette syndrome. So the focus of today's lecture is going to be on the overview of comprehensive behavioral intervention for tics, or CBIT, as it's called, in adult patients with chronic tic disorders. So again, we're not going to go through the other aspects of diagnosis and symptoms and pharmacologic or medication management, but we're really going to hone in on comprehensive behavioral tics and how it really can be implemented in the adult population and not just in the children population. Next slide, please. Give Hannah a second here. There's been some. There we go. Perfect. All right, so what are we looking to do in terms of objectives? Well, obviously, it's one thing to say, yeah, let's do comprehensive behavioral intervention for tics, but we also understand the medical evidence behind that, right? So a lot of what we recommend in the medical field is based upon data. And again, it'll be a little bit beyond the scope to go through all the statistical analysis and things like that, but it's important to understand, why we think this intervention is helpful based upon medical evidence. Then what we're going to do is set the stage and discuss the real life implementation of CBIT specifically in adult patients here at the University of Rochester. And again, this is just going to be our center's experience with regards to things, but how we really implement that into our adult population. And last, we're really going to also look at the potential limitations, barriers, and obstacles that we see in CBIT for adults with tics. There are different sometimes access or success barriers for which we see when trying to implement CBIT. So we'll certainly look through all that, but hopefully this is really informative in terms of educating everyone that this really is a very reasonable as well as beneficial intervention for those with tics. Next slide, please. Having some technical difficulty. All right, there we go. So, before we get into CBIT, really the biggest thing when we look at individuals with tics, whether it's children or adults, is do we actually need to treat the tics, right? And that is the same premise for any type of movement disorder that someone has, whether it's tremor and Parkinson's, Korean Huntington's, or tics and Tourette syndrome. Are they bothersome enough and impactful enough in someone's quality of life that warrants treatments? And again, you have to consider different ways that can be the case, whether it's, how the tics impacts individuals with their activities or school or work, social interaction, self-esteem, discomfort. So again, when we look at that term kind of bothersome, what is that threshold to treat? That's going to be very different for everyone. And that's not just in the child population, but also in the adult population. So the first thing that we as clinicians have to think about is it bothersome enough for the patient that we want to treat? Because a lot of times education really is sufficient in terms of understanding what is Tourette syndrome, what are the ebbs and flows that you're going to see. And then again, when we look to treat, it's not necessarily elimination of symptoms. Obviously, that would be amazing if we're able to do that. But it's really to improve the frequency and severity of symptoms that improves quality of life. And so when I talk to patients about the goals of treatment, again, I think if elimination was the absolute goal, then I would probably fall short most times. And we're really just to improve the frequency and severity of symptoms to improve quality of life. Again, this is more for the children aspect, but also as parents, sometimes they have children with tics. And, we really want to make sure how it impacts the individual. And we don't want to necessarily treat the patient, whether it is adult or child, based upon what other people's perceptions are about the tics. And we also want to treat the most bothersome symptom first. As many people know, Tourette syndrome is a lot of times just the tip of the iceberg with regards to motor and vocal tics. There are a lot of different medical comorbidities that we can see go along with Tourette syndrome: anxiety, depression, OCD, ADHD, which again are going to be outside the scope of this lecture. But a lot of times, yes, the tics can be bothersome, but so can anxiety and depression and OCD. And you really want to look at what is the most bothersome symptom first, treat that, and then go from there. And also you have to consider this: tics wax and wane, they ebb and flow, they come and go. And so a lot of times you'll see a natural transient increase in the frequency and severity, and then a lot of times you'll see that decrease. So again, just understanding the natural phenomenology and chronologically of how tics kind of ebb and flow and come and go is really important. And a lot of times tics worsen with stress, but that's not always the case. Now, the last point in terms of, tics typically improve with age. Well, that is what we tend to see at times, but that's not always the case, because there's certainly adults with bothersome tics. And, those attending today probably understand that. And also me as a physician, I see patients across the lifespan. And certainly I would say at least 25% of my patients, I'm still actively treating the tics. So yes, tics do improve with age a lot of times, but not always. And we need to continue to address the needs of those patients with bothersome tics. Next slide, please.
Oh, I'm so sorry. Let's see here.
Yeah, see if you can go to the next one from there.
Let's see.
Hannah, do you see like a little arrow button or anything like that on the bottom of your PowerPoint? Oh,
There we go. I think I
there
was
it
just
is.
able
I
to
would
get
just
it.
keep it in that. Yeah. Okay, great. Yeah,
Yeah.
just keep it in
Yeah.
that slide. All right.
Perfect.
So again, when we talk about treatment of Tourette syndrome, here's a list of obviously all the different interventions. The top part is what we're going to talk about today in CBIT, but it's also important to understand there are pharmacologic interventions, whether it's the alpha-2 agonists and guanfacine clonidine, Topamax, neuroleptics and the antipsychotics, VMAT2 inhibitors. So again, there's various treatment aspects to Tourette syndrome. But CBIT can be very effective and is something that we shouldn't overlook, especially if patients are a good candidate. And last, again, you just want to make sure that you address the whole patient, not just with the tics, but also any other comorbidities that are present in terms of ADHD, anxiety, and depression, because a lot of those symptoms can just be as impactful in quality of life as the tics themselves. And a lot of times there's multiple symptoms that need to be treated, but you have to be strategic as the physician to address each one by one. Next slide, please. So when we look at comprehensive behavioral intervention for tics, it really is considered first-line treatment intervention for bothersome tics. You know, a lot of times we consider medications, but really this should be first-line treatment, but there are obviously caveats to that in terms of access to treatment. Do they have a premonitory urge? Again, a lot of different things that we'll go through, but if able, this is what we would recommend. It is a form of habit reversal therapy, but I don't really like that terminology because when we hear about habits, that's not really what considered our tics, okay? But that's just under the umbrella term of a habit reversal therapy. And when we look at the methodology, first, it kind of looks at patients to become aware of their tics. That's the premonitory urge. A lot of times patients with tics, not always, will have this urge or sensation or buildup prior to the tics. And that's then where we'll utilize to develop what's called a competing motor response as what we will use for the bothersome tic. And again, there are ways that we can make changes day to day in activities that can be helpful in reducing tics, but really we utilize that premonitory urge and then we develop a competing motor response for the bothersome tic. And Hannah's going to go into that more in depth later on and how we implement that, but that's essentially kind of the fundamental idea behind it. Now, when we look at, well, who really provides this? There are various providers that can. It's not just psychologists, PhD, or neuropsychologists. As we can see here with Hannah, occupational therapists can be very effective at delivering this treatment. So again, there are various people, but you need to be trained in it, right? Not everyone who is a psychologist or neuropsychologist or occupational therapist has that specific training in CBIT. And so that certainly can be one of the barriers and limitations to being able to have access to it. You know, the TAA has been doing a great job in trying to increase access to that and provide training programs for various providers, whether that is occupational therapists, psychologists, or neuropsychologists. And in general, as we'll go through, it's typically about 8 sessions over 8 to 10 weeks in terms of the treatment. So it's not a sustained thing over years and years. It's really a targeted therapy to help improve the symptoms. Next slide, please. So as I mentioned before, it's good to understand what the evidence is, right? It's good for us to say, well, we should do CBIT, but what is the evidence, the medical evidence supporting this? So there have been various clinical trials looking at CBIT and tics, and I'm not going to go through all of them because that's beyond the scope of this lecture, but I'm going to take you back to the original, the OG, in terms of really those trials in both children, which I'll show here, and then in adults that really drove the pathway for us to realize that this is a very reasonable and first-line treatment. So let's first start with the children. This was about 15 years ago. So this is, again, not a treatment that just came along within the past 5 to 7 years. It's been around for a while. What they did is they took 126 children aged 9 to 17 with Tourette syndrome or a chronic tic disorder. And what they did is they randomized them to 2 groups. One group had the CBIT, the interventional arm. Then the other was the control group in terms of just providing supportive therapy and education. And what they found in terms of the outcome was that the behavioral intervention for CBIT led to significantly greater decrease in the YGTSS. So what does that mean? Basically, in all movement disorders with clinical trials is that we have to have motor outcomes. You know, the UPDRS in Parkinson's, UHDRS in Huntington's. The YGTSS is just an outcome that we use in clinical trials to assess tics. And essentially what it showed was that there was a significant reduction in that score compared to the control group. In addition, there was a secondary outcome looking at the Clinical Global Impressions Improvement Scale. What is that? It's basically a scale that clinicians use from 1 to 8, 1 being very much improved, 2 much improved, the other end 8 very much worse, 7 much worse, and 7 in the middle, neutral. That basically showed that there was, again, a significant reduction with the behavioral intervention in the Clinical Global Impressions Improvement Scale compared to placebo. So those two primary outcomes were met, and they're statistically significant. The dropout rate was only 9.5% and was pretty similar between the two treatment groups. And interestingly, what they showed was that the treatment was durable. 6 months later after this, about 87% of patients still responded with CBIT. So this was the initial trial that kind of led this movement. And going into the next slide then, if you don't mind, Hannah, is then, okay, well, we know that it's helpful in children. Can we translate this to the adult population? And so they essentially took a similar amount of adults with Tourette syndrome or chronic tic disorder, 122, aged between 16 and 69, again, randomized them to the CBIT group or a control group, which was more supportive therapy and education. And what they again found clearly was that the behavioral intervention with CBIT significantly reduced the YGTSS, which is the scale that we use for tics, compared to those in the control group. In addition, that other outcome with regards to the Clinical Global Impression Improvement Scale was also significantly reduced more in the CBIT group than in the control group. Dropout rate, a couple percentage points higher in the adult trial, but again, was similar between treatment groups. And again, they show that treatments were durable with continued benefit 6 months post. So again, I'm not going to go through all the different literature, related to CBIT, but we do know for several years now, 15 years at least, that this has been an effective mode of treating individuals, not only in children, but also in adults. Next slide, please. So this is a graphic representation primarily of the Clinical Global Impression Improvement Scale, where in the child study, in the treatment group, 52.5% rated themselves as either very much or much improved, or that was from the clinician, compared to only 18% in the placebo. And in the adult study, 38.1% were either very much improved or much improved, compared to only 6.4% in the control group. Next slide, please. So given that now I've kind of presented the medical evidence, what we're going to do is transition now to Hannah to really go through the nuts and bolts in regards to the implementation of CBIT in our adult population. Hannah, you want to take it from here?
Yeah, great. Thank you. Thanks so much, Dr. Morrison. So yeah, we're going to talk about what CBIT is and what it entails, and some of all the tasks that it takes to participate in CBIT. So as we talked about, CBIT stands for Comprehensive Behavioral Intervention for Tics. The main goal is to help individuals with tics and Tourette's have very specific strategies to help manage the symptoms, as well as reduce frequency and intensity of the tics. This is achieved by working on internal factors using habit reversal therapy, as well as addressing the behavioral and environmental factors. Also, the main goal at the end of completing the program is that you learn strategies to manage any potential tics in the future. So you want to be able to take this program, use the format, and apply it throughout the rest of your life. So who's appropriate for CBIT? Patients who are successful in CBIT can really be any age. I've worked with kids as young as 5, all the way to adults in their later 70s. So I have the question marks there because I think anyone at any age could participate in CBIT. The most important factor to be successful in CBIT is that the tic is bothersome to the individual. Participating in CBIT takes a certain level of self-awareness. So you have to have the ability to be able to focus on the sensations with the tics, as well as tolerate a little bit of discomfort. We want our patients to be ready and motivated to participate fully and feel that it's the right time to focus on the tics. So for example, if there's a big project in work and fitting the appointments in and thinking about your tics during that time might not be the best option, then we say that's okay. We just want you to participate when it's the right time. So once a neurologist or a primary care physician refers a patient to OT for CBIT, the first thing that we're going to do is an evaluation. So I'm going to gather the information about the tics, so your history of tics as well as what's happening currently. We're going to discuss the impact that tics have on your daily routines or how the tics can be bothersome to you. I want to know what makes tics worse and what makes tics better and what strategies you're already using. Also, during the eval, I'm going to explain all about the program. So that way, by the end of the evaluation, we can make a decision if it sounds like you're ready and motivated, and if it's the right time to participate. After we decide to engage in the CBIT, it's 6 to 8 sessions over 8 to 10 weeks, where each session we focus on habit reversal therapy as well as function-based assessments and intervention. All throughout the program, we're working on psychoeducation, relaxation techniques, relapse prevention, and figuring out what can help stay motivated. So each session throughout the program, just to give another visual, we work on awareness of the tic, awareness of the urge to do the tic. You learn something called the competing response. We focus on all the behavioral components, and then we practice. The first component of CBIT is the internal factors of tics. So we want to work on gaining awareness of the tic happening. We do that by self-monitoring, response description, response detection, and learning any early warning signs. Then we're going to describe the tic as fully as we possibly can. So in OT, that's called the task analysis. What muscles are you using? What order? What's it feel like? Where is it happening? The next step, once we have awareness of the tic, is recognizing the premonitory urge. So we want to recognize the internal signal that the tic is about to happen and look for any external signals that the tic is imminent. Some common descriptions that I hear when people describe their urge are tension, itching, pressure, burning, like a tickle, like something just needs to move, feeling like something is there in that area, or like something is missing and that movement is going to fill the space. After we have those factors down, then we start looking at what's called a competing response. Okay, I'm going to escape the screen. And we are going to look a little bit at what a description for a tic might look like.
So we're going to use habit reversal training to work on your eye tic. Okay, so you remember there are different stages to this.
Yeah.
And the first stage is that we get to know your tic really well. So we need to do a tic description. So can we start with you thinking about where you feel the tic coming? Where do you feel
Just everywhere in my eye, just my whole eye.
all around your eye. So the top of the eye, the bottom of the eye.
Yeah, everywhere, just my whole eye.
Okay, and is that quite strong, that feeling?
Yeah.
Okay, and then when you get that feeling, what happens next? What's the first bit of the tic?
Roll my eye upwards like that.
Okay, let me try that out. You're always to the same side?
No, just up.
Up, okay.
And
then
then,
what happens?
and then I blink.
And then you blink, quite a big blink,
Yeah, and then it goes forward. My eyes go forward again.
and then your eyes look to the front again.
Mm.
Okay, so you feel the feeling all around your eyes,
Mhm.
then your eyes go up, and then you blink, and then that's
Yeah.
the end of the tic. Okay, so there's kind of 3 parts to it. We feel the urge first of all, then the eye goes up, straight up, then a blink, and then it's done.
Mhm.
Can I just check in with you? I thought I saw maybe something happening around your nose or your mouth. Got the feeling maybe the left side of your mouth moved a little bit. What do you think?
I don't feel it.
You don't feel it? Okay. Why don't we do this? Why don't we get used to you knowing when the tic's happening? Can you feel it when it's coming?
Can I feel it?
Yeah.
Yeah.
Okay. So let's make sure you get really, really good at that. Okay? So we know that the feeling is around your eyes, then your eyes go up, then you do the big blink, and then the feeling goes away. And what's going to be a good tic blocker that you can practice with me here now?
I really don't.
Okay, let's see. You see the PowerPoint again? Let's get there.
We can see it.
Yes.
Thank you. Okay, so there they went through all the components of what's happening with that young man's eye tic. The next piece that we move on to is applying the competing response. So I have to say competing response and strategy, I use these words interchangeably. So we also use the acronym CR. So all of those mean the same thing. The competing response is a voluntary action or behavior that's incompatible with the tic, while still maintaining participation in daily activities. When we're choosing a competing response, I want whomever I'm working with to be involved in choosing a competing response. So we're going to talk about options. We're going to see what's comfortable, what feels right, and making sure that it's really going to be applicable in all the things that you have to do in your life. Each session, we typically learn one competing response for one tic. As the program goes on and you get used to how the flow and how things go, sometimes we can group them together and make life a little bit easier. If the competing response is not effective, we work on learning a new one. So sometimes people come back and give me feedback that it wasn't the most comfortable, or it just, it wasn't really working out. So we make those changes as we need to. To choose a good competing response, we want to find something that's incompatible with the tic. So most of the time we start with an opposite motion and we just work from there. We want the competing response to be less noticeable than the tic. The competing response should be applied anytime, any place. And we must be able to maintain the competing response for 1 minute or until the urge is gone. That's where the discomfort, especially when we're first trying it out, might come in. So we have to have a little bit of distress tolerance to be able to kind of push past that initial feeling. So some examples of competing responses that we might move. If we have leg movements, a competing response could be placing your feet on the floor and pushing down, locking your knees together. For mouth or facial movements, we might do something along the lines of clenching your jaw and pushing your lips together. Or you could let your jaw go slack with a conscious effort and apply a deep breath. For eye blinking, slow, controlled movements with that effort, so feeling your eyelid go down and up. Vocal tics, we're going to use a diaphragmatic breathing, and whichever pattern feels best to inhibit the vocal tic from happening. And for a shoulder raise, we'll do something like depress your shoulders or push them down. So here we have the cycle of a tic. So we know there's premonitory urge, the tic happens, and then you have relief. The competing response is meant to inhibit the tic from happening. So there we're breaking the cycle of the tic. And by preventing it, your brain learns, okay, that urge doesn't need to happen as strongly, or I have this strategy to stop the tic from happening, and you can control the movement, hopefully decrease the symptoms associated, like sore muscles, or feeling embarrassed, or feeling annoyed by the tic. Okay, one other video, this one's a little bit longer, where we're gonna watch a teenager practice using a competing response with support from Doug Woods, who provides training.
That we're going to ask you to do. We're going to kind of come up with something together, but it should meet 3 rules. All right. So any exercise that we choose should first be something that when you're doing the exercise, you can't do the tic, or the tic's a lot harder to do. That's the first thing. Second thing is it has to be something that's less noticeable than the tic itself. So for example, you can get your head stop going by going like this. That would look a little strange. Yes. Maybe even more strange than a tic might look. So we don't want to do that. All right. Third part of the rule is that it has to be something you can do for a minute or until the feeling goes away, whichever takes longer in almost any situation. So it has to be something you can do pretty much in any situation you're in that you can hold for a minute. All right. So can you think of something that might do that?
No.
okay? Sometimes that might be the case. And as a therapist, ideally we want this to be a decision between the child and myself, the therapist. I know what I want, I know what I think will work best, but I want the child to learn how to come up to this by themselves, because I want them to be able to deal with this in the future as they go along. This is a skill they should learn, that they don't need me anymore. I want to put myself out of business if they learn the right skills. If they've learned how to do this, I am not necessary. That's the whole point. So in this case, if he can't think of anything, then the first thing I'll do is say, okay, well, I'll give you an example. So for the neck jerking thing, one of the common ones we use for neck jerking tics is slightly tensing your neck. So it would be like this. It would look, I would want you to drop your chin just a little bit, and I want you to hold the sides of your neck gently. Not with your hands, but I mean tight gently. All right? Now it should be gently. I don't want your neck quivering because it's so tight. Okay, but it has to be tight enough that I can't really push your head over. All right? So it's that kind of thing. And I want your chin down, so you should feel a little tightness here. You should feel a little tightness here. All right? So that would be the exercise. All right? Now what I want you to do is to do that exercise for a minute or until the feeling goes away, whenever you feel the feeling. Now, here's what I'm going to warn you about. It's going to build up. Okay, when you start to do this, the feeling will get worse. It'll get higher and higher and higher and higher, and it'll feel like, I cannot take this anymore. That's when you got to double down and wait it out. Because what normally happens is after a few minutes, it kind of fades away. All right? And then it gets easier and easier and easier and easier. All right? Now, that doesn't always happen. It doesn't happen for everybody. And sometimes it just takes a lot of practice to try to, to go longer and longer and longer each time you do the exercise. But you try as hard as you can to hold it back for a while and see, and just sit back and kind of watch when you're doing that exercise. Sit back and watch what happens to that feeling. See what happens to it. Watch it go up, watch it go down. Just kind of take a distance from it and see. All right. So here's what it would look like. Let's say I'm sitting there, and all of a sudden I have that pressure in the back of my neck. What I would do is go like this. And I would hold it. And now while I'm doing this, I'm not just sitting there thinking about that. I'm talking, I'm engaging, I'm doing what I'm supposed to be doing, paying attention to the teacher, watching TV, playing a video game, whatever it might be, but I've just got my neck a little bit tighter. Okay? At the end of the minute, I ask myself, do I feel like I have to do it still? If I do, then I just kind of keep going with it. It shouldn't be so tight that it's hurting. Okay? If at the end of the minute, the feeling's gone, cool, I let it go. All right, I don't worry about it. All right? And then the next time it comes up, I do it again. All right. If you miss it, like if the feeling has shown up and gone away, and you've started to tic already, you've started to do the tic, just stop and then do the exercise. Right. So it looked like this. I'm sitting there watching TV. I feel the urge. I do the exercise. Minute passes. The feeling's gone. I let it go. Then I'm sitting there and I don't notice the urge, but I go like this. I would stop, put my neck down, and hold it for a minute until the feeling goes away. All right? Does it make sense? Yeah. All right. So why don't you practice it once? Okay. Do you have the urge?
Yeah.
Okay. Good. Now tell me. Yeah, it's good. But pay attention to me. Talk to me. Okay. Don't go into the urge. I just want you to tell me on a 0 to 10 scale, how strong is that urge right now?
8.
Good. Okay. That's fine.
7, 8. Yeah.
Yeah. Okay. So just now back to football. While we're talking about football. What year are you in school? Freshman?
8th grade.
8th grade. My goodness. Big 8th grade. So I take it you started on your football team.
Yeah, some stuff. Some stuff not. Yeah.
I'll make sure you keep your neck down. So you played defensive line. Did you have a lot of sacks this last year?
Yeah, a couple.
Yeah.
I had one big tackle. It was awesome. That was on kickoff.
Oh yeah. Oh, that's where you get some good speed.
I love kickoff.
Yeah. You really just destroy somebody on that. Where's your urge right now? 0 to 10?
Excuse me?
On your urge 0 to 10?
Probably about a 9.
Okay, good. So, what do you play on offense, or do you only go defense?
I basically just do defense.
Oh, okay. Have you played any other positions other than defensive line?
Kickoff and defensive line. That's basically all I do. I played some nose guards, just a little bit.
Yeah. You like which position on the line do you like best?
I have to say my favorite overall in the football.
Okay, I'm going to stop us there just in interest of time. So as they continue, he expresses that the urge goes down over time, right? But if you noticed, it was there and went up a little bit higher. I wanted to show them chatting a little bit. We'll talk about this a little bit, but that's my favorite part about CBIT. I get to know a lot about the patients that I work with because we use chatting and card games and things like that as opportunities to have a little bit of distraction while you're focusing on using these really challenging strategies. The whole point of using the competing response is that people describe that having that very specific strategy to help control the tic just feels good, right? Like you've got something to reach to say, oh, this helps, this controls it. Also, we want to reduce symptoms associated with tics. So pain, like we'll use this kid as an example, like maybe pain in his neck or maybe social implications or people thinking that he's responding with a nod, but really he was just having a tic. All of those are important parts, right? So the competing response helps control the tic, therefore controls the symptoms. And then over time, we're hoping to reduce the frequency and intensity of the tic and the urge. After you get your competing response down, what we work on next is the external factors. So we want to identify any factors that may be impacting the tic or impacting the ability to use the competing response effectively. So we'll do this by interviewing our patients and asking about anything that happens before and after each tic. We'll talk about how they're using their CBIT tools and how they're incorporating it into their workday or parenting or in social functions. And then we'll develop some plans. So we'll see what strategies might help reduce tics or help you use your competing response a little bit more easy. And then we'll talk about how these strategies, again, can be applied throughout your life. So this example as for using functional-based strategies, it comes from a 32-year-old female. She described that she was at work in more of an office setting and a social setting, and she was able to use her competing response all day. But as soon as she transitions into her car and has that first like letdown, the neck tic comes out. So what we discussed was deep breathing or other calming strategies during the transition to help keep our nervous system a little bit calmer, a little bit more relaxed, hopefully reduce the number of tics coming out. We might use that transition time to either really intentionally practice your competing responses or other strategies, or right when we first sit down in the car, use that time to track the success rate. So we use a strategy of having a visual of counting the amount of times you're able to use the competing response or the amount of times the tic comes out. And then some people respond really well to having visual strategies. So just a little reminder in the car, say, oh, okay, your competing response is to tense the front of your neck. So that visual is there just to tell her brain, hey, this is what I want you to do at this point. The next example is from a young man about 25, and he worked at a restaurant. So he described, I work in a restaurant industry, is fast-paced and can be intense. My verbal tics increase when orders are going out quickly. My coworkers think it's funny and might do things to trigger the tic. I don't mind, but it becomes difficult, and eventually I need to go outside and take a break, even during peak times. So his tics were getting so high that he couldn't perform his work function, right? And is really exacerbated by his coworkers. Although, he describes that these are his friends, he's been there a long time and feels comfortable with that and kind of feels like, describe being in on the joke and enjoying that. But we came to a point that we saw that it was really impacting what he needs to do. So we worked on deep breathing exercises to use through or before those higher stress situations. So we had a general idea of what the peak times would be. We discussed that, although, taking a break during work is fine, but his work function is kind of changing and we don't want that reinforcement. He practiced the competing responses intentionally during times of higher service. His coworkers also kind of became an ally and helped reduce the triggers as well as help giving reminders for using the competing response. And they really became that supportive piece for him to be able to use the strategies and stay right in his work function. So like we were discussing with my last gentleman, the 25-year-old in the restaurant industry, it's really helpful to have social support. So having someone who knows what you're doing and can support you in doing that, they're able to praise each time you're using the competing response or help you to remember to use the competing response, both in practice and in daily activities. Their job is to focus on the competing response, not the tic. So we want encouragement instead of punishment, right? So some examples of that is I want to hear language like good job using your competing response instead of good job not ticking. So all that language going back to using the competing response instead of like don't or stop, right? Our brain doesn't always like to hear that. We like to hear the things that we're supposed to do. So like many things in the healthcare system, there are some barriers. The first one affecting access. So it can be hard to find a provider who is adequately trained in CBIT. A lot of people, we have a really large catchment area in Rochester. So a lot of people have to travel pretty far and take that time to attend appointments. You have to consider life to like work schedules, your kids' schedules, spouse schedules, things like that. There are some insurance limitations, and although occupational therapy typically is a cheaper option than neuropsychology or psychology, sometimes there's visit limits for therapies, or there might mean to be more of a medical need to justify services. Since COVID, we've been able to use telemedicine for ongoing treatment as occupational therapists, which has been extremely helpful in expanding our catchment area. I've worked with people all over New York State, and even some like Northern PA. There are some pros and cons to using telemedicine, obviously accessing more people, but Zoom has obviously some technical difficulties as we see tonight. Also, Zoom cuts out background noise, so sometimes I miss tics both visually and auditory wise. So Zoom might assume that tic is background noise, and I just simply don't hear it through the screen. Some barriers that we find can affect success in CBIT is just not having that support person, right? In pediatric patients, patients usually come with a parent, right? So that's kind of built into the program. Adults, you might have to kind of seek that out or decide who that's going to be. Sometimes comorbidity symptoms might impact treatment. So if ADHD or ADD, we might have a hard time attending to the sensations or attending to me as a provider, or if anxiety, OCD, other symptoms are feeling higher than the tics are being bothersome, then it's not the right time to participate. As we talked about, motivation and readiness is extremely important. In terms of cognition, we have to be able to tolerate that distress and be able to adequately explain what is happening with the tic and what's happening with the urge. Again, like many things in the medical system, my schedule or neurology schedule might impact treatment time. And maybe by the time you're back on my schedule, tics are a little bit lower and might decide it's not the time to participate. Another interesting component when I'm working with adults is that I have found that adults are way better at suppressing their tics than teens or any of my pediatric patients. So I have to really keep my eyes out. Anytime I look down at the paper or the computer, I'm usually seeing a tic out of the corner of my eye. So it's not always as visible. So I might need a little bit more explanations or say, like, as best as you can, let the tics out in this situation. And I know that's not always easy. So just some things that we think about or that I've heard over the years in terms of misconceptions about CBIT. People might ask, if it's neurological, why are we using a behavioral approach? But as we describe, this behavioral approach helps change the reaction to the urge, right? And then we're reducing the symptoms, you're gaining control, and it just feels better. It isn't the same as suppression, because suppression is holding the tic back, right? Like choosing not to do the tic. Here we have an active strategy to stop the tic. And again, that has been proven to have a better effect on reducing the frequency and intensity. Similarly, we say people might ask, well, isn't doing a competing response just like having a new tic? And it's not, because you're actively in control of what the motion is. And then people ask me, what if the competing response becomes a habit? And I say that's fantastic. The less you have to think about it, and the better it is, right? And the easier it is. And then last piece is that CBIT is not fun. And I argue that all the time, because CBIT's one of the most fun part of my day, and I do a lot in pediatrics, right? Again, I get to know a lot about people. We play games, we chat. I get great book recommendations and movie recommendations. So I love that part of my job. Okay, and I'm going to kick it back over to Dr. Morrison, just to kind of review a little bit of the evidence.
Yeah, so again, this is going to be, I think, the last slide of our presentation, and I just kind of wanted again to summarize kind of the highlights of today's presentation. Again, overall, CBIT is definitely one of the few interventions that demonstrates a positive effect over 4 to 10 weeks and comparable improvements, that we've seen in pharmacological interventions. And so that's when I talk to patients, in other words, is that, we have medicines and we have CBIT, and truly, in my opinion, they can both be just as effective for tics. So if we're able to, we have access to, we have the premonitory urge, the insurance coverage, all these different potential barriers to access to treatment or success, then we really should look at CBIT, in my opinion, as first line, but it is easier said than done. And that goes to the second point again, in terms of, the CBIT yielding pretty similar benefits compared to like guanfacine, which is what we consider first line from a medication or pharmacologic standpoint. CBIT helps enhance individuals' self-perceived occupational performance. Again, we should consider it first line, and it can be very highly effective. So again, really today was to focus on non-pharmacologic, non-medication approach for tics, and we truly believe that CBIT can certainly do that. Now, again, there's rooms for improvement, right? We really got to look at improving access, improving training, and things like that. And it is easier said than done. But if you're able to find someone locally that is familiar with this treatment, then it certainly is a reasonable consideration. And I think that is it. Let's go to the next slide.
Yep.
Just the reference. And then I always like to end all my lectures in terms of, I couldn't be here today if it wasn't for my family, obviously, to give me the time to have the little ones while I can give you guys this lecture. With my wife, and there's my 2 kids. We were in Barcelona the other year. So again, I always like to thank them, just to be able to give me the opportunity to do this. And we can go into the questions then. I know that there's several that have popped up in the Q&A. So I don't know if you just want us to go through one by one, or you've kind of prioritized them, whatever you'd like to do, and we'll, stay as long as we need.
Sure. No, thank you for segueing into the Q&A. Before we start the Q&A, I do want to, if you don't mind, I'm going to share a QR code actually for our program survey for tonight, because I know a lot of you find this topic very helpful. So we want to be able to make sure we capture your feedback. So if you don't mind, I'm going to leave this QR code up and then we'll go straight into Q&A. Okay, everyone? So I'm going to go ahead and do that right now. And then panelists, just give me a thumbs up if you can see my screen here. Perfect. So, all right, so we go straight to Q&A there. There's a QR code. And then also too, if you have a great program idea, especially for adult programming, our wonderful Alexandra here leads that program department. We're happy to get some ideas from you. So there's program ideas at Tourette.org. If you have a topic you'd like for us to work on, go ahead and shoot us an email over there. Okay. All right. So Hannah and Dr. Morrison, I'm going to actually go by kind of which questions were the most like upvoted.
Yeah.
It seemed like some people thumbs up a lot of things. So
Yeah,
the first
good.
question, would be wondering how long a course of CBIT therapy may take / how effective can it be? And then this attendee just shared a little bit of background about themselves. They're currently 51 years old, currently awaiting an official diagnosis, trying to get some health insurance things to cover the CBIT, and shared a bit of history there, as you can see. But I think the main question is like how long a course of CBIT therapy may take. So go ahead.
Yeah, Hannah, I don't know if you want to take that since, you
Yeah.
do it day in, day out. Again, no, but yeah, if you want to answer.
Yeah, I'll talk about within our system, right? So typically a patient's referred from neurology, and usually from once that referral is placed at the visit, typically, it's about 6 weeks to get onto my schedule. We have our evaluation, and then what we do from there is find the most convenient time to schedule all 6 weeks at once. So that it usually is about 3 to 4 weeks just to get that really convenient time. And we'll schedule those 6 weeks, and then what we'll do is have some buffer sessions. So all in all, I mean, considering all components from neurology appointment to being done with CBIT, I would say about 3 to 4 months, right? And like I mentioned before, the idea is that you have the strategies to use for ongoing tics. Or if a new tic comes up, you're able to use the same format and apply it yourself. But sometimes people do come back for little updates or just to review things.
Anything else, Dr. Morrison, or?
Yeah, I think, Hannah made a good point is, trying to get all the appointments on the books, right? In these clinical trials, it was structured absolutely every week, back to back to back to back to back, right? But in real life, you come to a visit and then you try to schedule, my schedule's booked out, Hannah's booked out, oh, I have work that day, right? And so then it becomes, every 3 or 4 weeks you're doing it and it's spread over. So, I like the way that, Hannah's presented it, trying to get them all in the book so that we have a clear regimented and doing it up front, within a structured time period rather than kind of having it go out for 3, 4, 5, 6 months just because of scheduling. So I think that's one unique thing, to kind of think about. And yeah, I mean, a lot of it just comes down to schedule, right? Life happens, people work, they have children. And so, that is one of the limitation barriers that we do it. But typically, right, it's, over an 8-week period of 8 sessions, again, plus minus with some tune-up.
Thank you both. Let's see here. Our second question is, are the CBIT session always in person or can they be remote? If remote, how effective can those be?
Yeah, so I'll definitely let Hannah kind of answer this. I think
Yeah.
this is an excellent question and something that is in flux from COVID. So yeah, if you want to.
Yeah, absolutely. It was completely new to me from 2020 on, providing telemedicine. So we have to provide, as occupational therapists is what I can speak to, I have to provide the evaluation in person. So no matter where you are in New York State, or like I said, Northern PA, you come to me here at my office, and we do the evaluation. And then essentially I'm saying to insurance, okay, I feel like this patient is appropriate to continue on via telemedicine, right? Because as occupational therapists, we treat a lot of different things, and some of it is just not appropriate to do on telemedicine. I don't have any concrete data for effectiveness for CBIT in person versus telemedicine, but just anecdotally, I do feel like it is as effective. I always tell people it might be a little bit more annoying, like I have to ask a few more questions or say like, oh, wait, was that a tic? Or, hey, just so you know, I heard the one tic, but I didn't hear the others, because Zoom will kind of take take some sounds and interpret it as background noise, and it just doesn't come through to me. So as long as you're able to maintain your attention on the screen, right, and can make sure you minimize distractions in your environment, I think it can be just as effective.
And I think one thing that comes into play, and Hannah, maybe you can contact, at least from a physician standpoint, we are not able to bill across the state via telemedicine. So the person has to physically be in New York State in order to provide telemedicine services. So, if I have someone from Pennsylvania, in theory, they'd have to drive across the border to New York State in order to do the telemedicine. So I think that probably is the same for occupational therapists. But right, there is some barriers there where we're not able to bill across state lines. And so for us, we really have to do the telemedicine visits in New York State for them to occur. Is that right for you, Hannah, too?
Yeah, that's correct. So I have, patients are often willing to just, drive, maybe find a parking lot, find a coffee shop or someplace that they're comfortable. And then we have that. But it would be the difference between maybe driving an hour, or half an hour versus driving like 4 or 5 hours to get back to Rochester for that appointment.
Great question. And I know someone put a question earlier in about how to find someone that practices CBIT in their location, or find a provider directory. You can use that to search via the zip code, your location, and actually search by CBIT as clinical expertise. And that maybe help you find someone within your area. So I wanted to share that. Let's see here. Alexandra, do you think we have like maybe time for 1 to 2 more questions. I know it's almost 8 o'clock, so I wanted to ask Hannah and Dr. Morrison. I know
Yeah.
time is valuable, so we can doing 1 to 2 more, and then we'll kind of maybe end it there, and whatever's left over, we can send to you for follow-up. Is that
Sounds
okay?
good.
Yeah,
Okay.
that sounds great.
Great. So we have a question from Natasha asking, there's a very wide range of tics. Is there data on types or categories of tics that is most successful for, like, for example, vocal versus motor, or tics that are grouped together versus
Yeah.
individual tics?
Yeah, so that's a really good question. And so the data that I presented on those original studies, listen, there's been other ones, obviously, at least in those studies, they didn't necessarily nitty gritty look at the motor. I mean, they did break it down in terms of the YGTSS for the motor and the vocal. And I believe in the childhood study, it was pretty similar in terms of like 3.6 to 3.9 points was the difference between motor and vocal. Interestingly, the vocal score was a little bit lower at baseline than the motor score. So the absolute ability to get difference is a little bit less if you start at a lower score. In the adult study, they did mention that the effect size was a little bit more on the motor tic than on the vocal tic per se. But again, the way that I look at it is that certainly it can be helpful for potentially both. But it is something more to potentially look into. And I don't know anecdotally, Hannah, in terms of your experience, whether success-wise for you see a difference in terms of treating motor versus vocal. Again, anecdotally.
Yeah, anecdotally, I'd say so not so much vocal and motor. What I find more challenging, based on what patients report, is motor tics and vocal tics that are more similar to actions that are going to happen anyway. So eye blinking. Sometimes people describe like a jaw movement that makes your ear pop a little bit, right? So that can be really hard to find something that's completely incompatible because you're going to do such a similar motion X amount of times in the day. So your brain has to work extra hard at like distinguishing, like, oop, natural blink, oop, that was a tic, right? So it just takes a little bit more work. But I don't have anything specifically to say like, if it can't happen or it's more challenging.
Yeah, I would say overall that, the ability to do both is there. So I wouldn't hesitate if you just have more motor than vocal or vice versa.
Absolutely.
Great. Okay, so we're gonna do one more question. And thank you everyone for submitting everything into this Q&A. Rest assured that we will capture those, and we're happy to forward them to our panelists if they're comfortable and they can answer them offline as well. So the last question for tonight is from Laura. How can this technique, CBIT, right, work when multiple tics are happening? The pressure to focus on like stopping and or reducing or replacing, I'm sorry, one tic likely would trigger all the other tics to occur more. So any commentary on that?
Yeah. Do you want me to jump in there, Dr. Morrison?
Yeah.
Yeah, so some ways that we kind of tackle that is that we focus one tic at a time. So if you're practicing here in the session with the competing response and we're doing we're working on your neck tic, but the eye tics are like kind of expanding, I don't even comment on it. We're just going to kind of get this strategy down, make it feel really comfortable and solid for you. And then after you've practiced that a little bit, you should start applying it in your life and we move on to the next tic. So it's usually one tic at a time, one tic per session, essentially.
Yeah, and overall, from my perspective, when I just refer and talk to patients in general about it, not that I deliver it, is that, certainly patients can have 20 different tics, right? We're not, in theory, going to have 20 different competing motor responses in general. In theory, you could, but you really got to focus on the ones potentially, depending upon the circumstance, that seem to be most bothersome, most disruptive. You really focus on those, maybe let the others go at the wayside. And a lot of times that's enough to improve symptomatology, frequency, and severity and quality of life. So again, I really talk to patients. You look at what's potentially most bothersome, you start targeting, kind of one by one, and then you kind of see potentially what's left over, but not focus on developing competing motor response for every single tic that you have.
Amazing. Well, that is all our time for today. I want to thank Dr. Morrison and Hannah Peck again. This was an amazing presentation, and we hope to have you both back again soon. To everybody that joined us tonight, thank you again. And I did put it in the chat, but this recording will be available within the week on our YouTube page, and that link is available in the chat as well. So thank you everybody again for attending, and we hope to see you all again soon.
Everyone.